Welcome, doctor.
Welcome all and good evening to everyone and who are participating in this meeting in Zoom and also online in YouTube. Welcome all for this lecture series again. And yes, okay, sorry for the interruption. Today's topic is going to be on inflammatory bowel diseases, and the target audience will be the MRCS, uh, the aspirants, those who are going to apply for MRCS and for FRCS graduates. Anyone who's watching on YouTube can also uh, post the comments on the chat box, and those who are on Zoom can post the comments on Zoom. Who can or they can comment uh, on the poll session as well. Going on to the topic as such, and today it is inflammatory bowel diseases, and everyone knows that it's a chronic disorder and has got a strong implication on medical gastro and also on the surgical gastro. Coming on to the first slide. Okay, so inflammatory bowel disorder, bowel diseases are nothing but it's a chronic relapsing immune activation. It's a chronic disorder, and it has got a period of remission where the symptoms gets resolved, and there is a relapse of symptom, and all these things are because of immune activation and inflammation. And the most commonest inflammatory bowel diseases which we know are chronic Crohn's disease and the ulcerative colitis. And the other inflammatory bowel diseases which comes under these group of disorders are microscopic colitis, or the plural form of colitis, and these are nothing but the primary collagenous colitis and lymphocytic colitis. And these are increasingly recognized. It's because of the endoscopy which we do for the screening purposes. So the Crohn's disease and the ulcerative colitis is not the only inflammatory bowel diseases. There are plenty of other bowel disease, inflammatory bowel diseases like primary colitis and lymphocytic colitis. So other known causes for inflammatory bowel diseases are diversion colitis and intestinal tuberculosis, which can cause granulomatous inflammatory bowel diseases, and radiation colitis and drug-induced colitis. And in 10% of the cases, we may not be able to differentiate between the Crohn's disease and the ulcerative colitis. So in general, the inflammatory bowel diseases are nothing but a chronic relapsing chronic disease of the bowel, and also it has got relapsing immune activation and inflammation. So this is the outline of inflammatory bowel diseases. And going on to the next slide. Okay, so this slide gives you an overall picture about Crohn's disease and the ulcerative colitis. In general, the Crohn's disease can involve any part of the intestinal tract, starting from the mouth to the anus. It can affect any part of the intestine, but the preferable site of involvement is distal ileum or terminal ileum and the proximal colon. And the Crohn's can involve in the esophagus, in the perineum, in the anus, large intestine, small intestine, but more commonly affects the distal ileum and the proximal. And the most important thing is it has got a full thickness involvement of the bowel wall. So the mucosa, submucosa, the muscle layer, and the serosa are all involved in Crohn's disease. Otherwise, and there is a skip lesion. There's a skip lesion between the two involved segments of the intestine. The most commonest clinical feature of the Crohn's disease is diarrhea and abdominal pain. The diarrhea accounts for 70 to 90% of the symptom, and abdominal pain accounts for 45 to 65% of the symptom. The rectal bleeding happens. The rectal bleeding is prominent in patients those who have Crohn's disease of the colon. As I said, Crohn's disease can happen in any part of the intestine, and the perianal disease accounts for 10% of the Crohn's disease. The Because of chronic diarrhea and because of the abdominal pain, chronic abdominal pain, the patient goes may have weight loss, and the unique complications of Crohn's disease is strictures and fistulas, which can clinically present as small bowel obstruction or large bowel obstruction, depending upon the site of the involvement of the Crohn's disease. Coming on to the ulcerative colitis, it starts usually in the rectum, and it ascends up on the left side of the colon, and it can involve whole of the colon, and rarely the patient can involve the terminal ileum, that is otherwise called as backwash ileitis. And someone calls from the okay, anyone can post the comments. I cannot give you the reply during the session. And coming on to the ulcerative colitis, starts in the rectum, and as I said, it ascends up in the left side of the colon, and then there can be a pancolitis or complete involvement of the colon. And there is something called as backwash ileitis. The terminal part of the ileum can get involved because of ulcerative colitis, that is called as backwash ileitis. The most important thing with the ulcerative colitis is the superficial epithelial layer of the mucosa is epithelial layer of the intestine is involved, sparing the muscular layer and the serosum, but the entire length of the colon will be involved. So the most important uh, differentiating point between the Crohn's disease and the ulcerative colitis is the skip lesion and the involvement of the whole segment of the whole length of the colon in ulcerative colitis. The most commonest clinical feature of ulcerative colitis is bloody diarrhea with urgency in passing stool. Coming on to the next slide, bit of history, and the inflammatory bowel diseases history starts in the year 1859, where the Samuel Wilkes, who wrote about a colitis called as idiopathic colitis, and after which Dr. Wilkes, he introduced the term called as ulcerative colitis, and he described it in large bowel with described about a large bowel dilatation because of the ulcerative colitis. In the year 1913, T.K. Dalziel published a case series about the inflammatory idiopathic small bowel inflammation, following which in 1932, Beryl Crohn, under whose name the Crohn's disease was named, and he gave the description of granulomatous inflammation of the terminal ileum, and he named it as regional ileitis, which is otherwise called as Crohn's disease. So this inflammatory bowel diseases has got its history starting from 1859, and it has got a definitive structure, and the disease pathology started investigating in the year 1932. So next, the incidence of the disease. These are the most important articles which were published in Lancet and Gut, the journals called Lancet and Gut. The incidence in relation to geography. Initially, the trend was the incidence was increasing in Western world, and presently there's a stabilization of the incidence of the diseases, both Crohn's and ulcerative disease in the Western world. And in this paper, we can see there is a stabilizing incidence is stabilizing in Western countries, but the burden remains high as prevalence surpasses 0.3% of the population. That means because of the treatment modalities, and there is the incidence the prevalence increases more than the incidence. So there's a the disease burden is increasing in all parts of the world. So the main thing which I want to stress is the incidence. Initially in the year 1950 it was increasing in trend, and presently in the Western world the incidence is stabilizing. Coming on to the next slide, and the global burden of the inflammatory bowel diseases is definitely increasing, because when the incidence of the inflammatory bowel diseases are stabilizing in Western world, there is an increase in incidence in the developing countries like Asia, South America, and Middle East. That means there is an increase on the increase of incidence in the developing nation, and there is a stabilizing incidence in the Western world, so which in overall increases the burden of the disease all over the world. And as such, when compared to the age incidence, when compared to the age, inflammatory bowel disease can be diagnosed at any age, and the commonest age group, those who are involved, are adolescents and early adulthood. And the UK statistics is nothing but the ulcerative colitis. The incidence of ulcerative colitis in UK is 2 to 15 cases per 100,000 persons per year, and the Crohn's disease, uh, the incidence of Crohn's disease is 6 to 15 per 100,000 population, and the prevalence of Crohn's disease is 50 to 200 per 100,000 population. So this is a graph which clearly indicates the age differences and also the disease incidence in men and women. The dotted line, the short, small dotted line, explains the incidence in women, and the dark dotted line incidence explains the incidence in men in relation to the age group. You can see in terms of Crohn's disease, even it can start the incidence of the diseases or the diagnosis even it can be diagnosed even in the early neonatal age, the age group of 0 to 4, and the incidence increases in the early adolescent group, where in Crohn's disease the woman outweighs the women are more prone for Crohn's disease than the men, and then the incidence decreases. But even at the age of 85, we could diagnose a patient with Crohn's disease or ulcerative colitis. In the same way, the incidence of the ulcerative colitis is again peaking in the age group of 25 to 29, and then the incidence decreases as the age increases. However, when the incidence decreases as the age increases in ulcerative colitis, the men are more prone for ulcerative colitis than women, in contrary to the Crohn's disease. So this is an article from the gut which shows there is an increasing incidence in pediatric inflammatory bowel disease, and this article says there is an incidence of uh, uh, inflammatory bowel diseases in the age group of 6 and less than 6, and they classified this thing as early onset inflammatory bowel diseases. Is as this is called as very early onset inflammatory bowel diseases. In this group of inflammatory bowel diseases, even the patient, those who are under the age of 1, are diagnosed with IBD, and it is otherwise called as neonatal or pediatric childhood inflammatory bowel disease. The criteria to say that it is early onset inflammatory bowel disease is 6 years of age, and they have found out there is a gene mutation in IL-10 receptor that is impairing the IL-10 signaling. So any patient, those who have IL-10 signaling mutation or IL-10 interleukin 10 receptor mutation, may have early onset or very early onset inflammatory bowel diseases, and that is called as VE, OIBD diseases. Okay, what is the past and the future burden of the inflammatory disease? As the disease burden, as the incidence is increasing in the developing countries and it is stabilizing in the Western world, there is a there is a uh, there is a increased prevalence of disease. So that in this article they say that there could be 1% of the 1% of the population in the group, inflammatory bowel diseases group, can have these diseases, and the disease burden will increase as the day passes. Coming on to the next slide. Okay, so this is about the etiology, and no one knows what exactly is the reason for the inflammatory bowel diseases. There are plenty of hypotheses which has been formulated, and they give the possible reason for the inflammatory bowel diseases. And the most important thing is it has got a complex etiology, and there has been 163 loci of genes which has been identified, and this says that it could be because of it's a polygenic disease, and there is a overly aggressive T cell mediated immune, and this is the reason, this is why the patient has got chronic chronic inflammatory disease. And it has been postulated that the intestinal microbiota or the intestinal microorganisms are responsible for the inflammatory bowel diseases, and there are particular intestinal microbes which can trigger the inflammatory bowel diseases, and that's the reason for the chronic inflammation of the intestinal bowel, chronic reasons for the inflammatory bowel diseases. So, as such, the inciting antigens for the inflammatory process has yet to be identified, and that's the reason the etiology is said as unknown. So, this is a difficult pathological pathophysiology of the picture showing the pathophysiology inflammatory bowel diseases. On the right, let's go part by part. On the right, there is a healthy state of the bowel intestinal wall. On the left, there is a diseased state of the bowel intestinal wall. Let's go. These are the microorganisms which are present in the lumen, and they say that these microorganisms are either destroyed by the IgA dimer or by the Paneth cells, which secretes defensins and the NOD2. And these are luminally destroyed by the IgA. When these Paneth cells gets this antigen into it, they trigger the mature dendritic cells, which in turn creates a series of activation of T cells, and then the autophagy or the bacteria is engulfed by these T cells, and these are the which produces inflammation, and this is the normal innate immunity of the bowel wall. However, in the diseased stage, what happens is this Paneth cells loses the defensin, and there is a mutation of the NOD2 gene, which allows all the bacteria to enter into the submucosal region, which triggers the THO cells, and there is a series of cascade of reaction which happens, and these series of cascade of reaction causes defective autophagosome or defective autophagy of the bacteria, which leads onto the chronic inflammation of the bowel wall, and this has been proved by plenty of hypotheses, and I'll let you know all these things in future slides, step by step. And there's and also there's something called as innate lymphoid cell, which has been activated with with series of interleukins like IL-13, IL-1, and all these things causes inflammatory cells which are present in the submucosal region continuously. Okay, So when it comes to the genetic aspect, the NOD2 is the NOD2, as I said you, which is secreted in the which is secreted by the Paneth cells in the intestinal mucosal wall. It says that NOD2 is associated with ileal disease and the younger age of onset, and these are responsible for many of the ileocecal resection. When the patient goes for ileocecal resection, these NOD2 gene mutation has been identified. There's an increased risk of reoperation when these genes are found, and there is an ethnic variation in the NOD2 gene mutation. When we know plenty of things about the pathophysiology of the inflammatory bowel diseases, and these are the monoclonal antibodies which are helpful for targeted therapy of the inflammatory bowel diseases. The most important thing which are involved are TNF alpha antagonist and TNF antibodies, and there is a antibody, monoclonal antibody, which are against P40 subunit of IL-23 and IL-21. And the most commonly used monoclonal antibody is infliximab and adalimumab, which are commonly in practice, and these are helpful for the maintenance therapy of the inflammatory bowel diseases. And as we know much about the pathophysiology of a disease, the targeted therapy are more useful in the treatment aspect. And the two genes which are more importantly recognized are the ATG16LIR autophagosome gene and IRGM genes, which are more involved in the targeted therapy. So when it comes on to the genetics of family history, um, when any patient, those who have Crohn's disease, the first degree relatives have highest chances of 8 to 10 times chances of getting the inflammatory bowel diseases. In other words, any patient can pass on the diseases to the first to their children 8 to 10 times. And 1 in 5 patient with Crohn's disease have Crohn's disease report having at least one affected relative in their family. So it can be either Crohn's disease or ulcerative diseases, and Jews are at 2 to 4 fold higher risk, and the concordance rate among the monozygotic twin is as high as 67% for Crohn's disease. And if it is ulcerative, relatively they have less risk of having the ulcerative colitis. So, what are the susceptibility genes? There's a study which was done in 2012 by Genome Wide Association Studies, that is otherwise called as GWAS studies, which has recruited more than 1,000 participants who had inflammatory bowel diseases, and the inheritance of Crohn's disease and the ulcerative colitis were studied, and they were not able to describe a Mendelian inheritance of susceptible genes in the patients, those who had IBD. However, they found that there were 163 loci which were related to IBD were identified, of which 113 loci were associated with other immune disorders, and the most common immune disorder which were associated was psoriasis and ankylosing spondylosis. And that's why we could see plenty of people with IBD or Crohn's disease with ankylosing spondylosis and sacroiliitis. And the genetic relations are related to disease locations, and more commonly the genetic associations are related to ileal Crohn's disease, colonic Crohn's disease, and ulcerative colitis. And the most important gene which they have identified is not to cod15, which is associated with CD or Crohn's disease. And this gene has not been associated with ulcerative colitis. Other thing which is important as a genetic perspective is they have found there is a gene or there's a genetic defect in the autophagy of the bacteria by the T cells, and these are the two genes. AT, as I said you, the ATG gene is not associated with ulcerative colitis. However, the IRG gene is shared with ulcerative colitis and the Crohn's disease. As I said you earlier, the very early onset inflammatory bowel diseases, which are more prevalent in the pediatric and neonatal age group, it has been found that IL-10 receptor gene mutation has got increased susceptibility for very early onset IBD, and also NADPH oxidase complex genes such as NCF2 genes are also mutation of these genes are also identified in very early onset inflammatory bowel diseases. And coming on to the environmental factors, any genetic mutation needs an environmental trigger, which has to be identified, which has to trigger the disease process. And there is a hypothesis called as hygiene hypothesis. That means the immune system of the body is not primed in the early ages, and that's the reason for the inflammatory bowel disease in the early adulthood. So there's relatively sterile environment which has been practiced during the early onset of the during the early period of the life, leads to the leads to the disease process in the early adulthood. And this has been substantiated by the decreased prevalence of disease in the rural area and on a farm, the people living in the farms or in the rural area. So this disease is more prevalent in Western world and also in the urban population rather than the rural area or the farm. And these are the reasons which are given for the hygiene hypothesis. And there is another reason which has been stated as increased prescription of antibiotics in the first year of life changes or alters the microbiota of the intestinal lumen, which can lead on to the inflammatory bowel diseases. And also, it has been proved that breastfeeding has a highly protective, is highly protective in the development of the inflammatory bowel diseases, which is more, which is why the Asians have less. It has been said that the Asians are more protective against inflammatory bowel diseases because of breastfeeding. And the smoking is protective for ulcerative colitis. Otherwise, they say quitting smoking triggers the risks, has an increased risk of developing ulcerative colitis, but it has got negative effects on the Crohn's disease. Likewise, vitamin D deficiency has got worse effects, or the increased incidence of ulcerative colitis of seen in patients with vitamin D deficiency. So overall, combining all the environmental factors and the genetic factors, the difference between the Crohn's disease and the ulcerative colitis is the smoking risks the Caucasians and Middle East in Crohn's disease. However, it is protective in Caucasians and the Asians. The antibiotic use in children, as I said, it risks in Caucasians, Asians, and Middle East, all the geographical region. However, the ulcerative colitis, it again risks in uh, um ulcerative colitis. Breastfeeding is protective all across, and oral contraceptive, it has been proved that it risks the causations, and there is no evidence saying that it's inconclusive to affect to trigger the ulcerative colitis. It has been proved that appendicectomy risks the causations to develop Crohn's disease, and it is protective in causations. And there's a low level of vitamin D risks both Crohn's disease and the ulcerative colitis. And the consumption of tea and coffee. It has been said that it's protective in Asians, and it also protective in Asians both in both Crohn's disease and the ulcerative colitis. Hygiene hypothesis, as I said, you unpasteurized milk and people those who are living in farm, large family size childhood are protected against these inflammatory bowel diseases and changing bowel habits like packaged food, fast foods, and increased use of antibiotics, increased amount of fat in the especially the monounsaturated fatty acids and polyunsaturated fatty acid consumption. An increased intake of sugar causes the inflammatory bowel diseases, and additives are also again proved to be a trigger for inflammatory bowel diseases. So this is the change in the microbiota or the microbial profile in the lumen of the lumen of the intestine, which triggers the inflammatory bowel diseases. And there's a conversion of the healthy microbiota to the unhealthy microbiota, and these are the food items which causes a healthy microbiota in the lumen of the intestine, and these are the food items which causes a poor microbiota in the intestinal lumen, which can trigger the inflammatory bowel disease. It has been proved that the decrease in these organisms like bifidobacterium or intestinal luminal bacteria of these kinds decreases the chances of inflammatory bowel disease. And these are the bacteria which has the increased incidence of inflammatory bowel diseases when these changes in the microbiota happens in the lumen. There is an increased chances of inflammatory bowel diseases. So, coming on to the gross pathological features of Crohn's disease, as I said here earlier, it's a focal disease. Crohn's disease is a focal disease. Always it happens at a particular point of the intestine, but there is a transmural involvement, or the whole thickness of the wall of the intestine is involved, and there's a focal area of marked chronic inflammation. The most important thing is the presence of aphtha is the earliest characteristic lesion of Crohn's disease, and it represents the area of immune activation, and the surrounding area of halo with erythema is a classical feature of an ulcer with a surrounding area of erythema is a classical feature of aphthous ulcer. It has been associated with HLA-DR, and there's a strong association. The aphtha heal in the bowel, and this has been proved when an ileostomy is done, diverting the intestinal content out of the area where the aphthous ulcer is present. The aphthous ulcer heals. So this shows the intestinal luminal content is the trigger for any aphthous ulcer or the trigger for the inflammatory bowel diseases. Large aphthous ulcers coalesce to form larger ulcers. A number of aphthous ulcers coalesce to form larger ulcers, and it can be in any different form, or linear in the forms of linear ulcers or in the form of stellate ulcers, or that's called as linear ulcers or serpiginous ulcer. And the endoscopy shows that classical cobblestone appearance of in the Crohn's disease with the linear or transverse ulcers which can intersect. So this is the endoscopic feature which shows there is an aphthous ulcer which has been shown in the green circles, which can be seen endoscopically, and there is a normal paste patches in the ileum with a ulcer or chronic ileitis, which causes linear ulcer with an exudate covering the linear ulcer, an exudate covering the linear ulcer. So the classical feature of a Crohn's disease is non-caseating granuloma, and it is present in the non-caseating granuloma is present in 9% to 66% of the population. It has been found in both involved segment of the Crohn's disease, sometimes in uninvolved segment as well. The most important thing is it has been present in any layer of the intestine. It can be even in the muscular layer or the serosal layer. and the mesenteric nodes are usually involved in non-caseate in producing non-caseating granulomas. The non-caseating granulomas can also be found outside the GI tract, like skin, eye, and liver. The most classical feature of a non-caseating granuloma on the serosa is like millet seed appearance, and these granulomas shows epithelioid histioid lymphocytes and eosinophil filled giant cells with no central necrosis. If there is a central necrosis, it can produce a granuloma, a caseating granuloma. However, in Crohn's disease, there won't be any central necrosis. It's just epithelioid histiocytes with no central necrosis, and it is sparse cast and it's not well formed. The classical feature of the pathological feature of the classical pathological feature of Crohn's disease is presence of lymphoid aggregates in submucosa and external to the muscularis propria is a reliable sign, and even when granulomas are not present. So the presence of lymphoid aggregate is more important classical feature, most important feature to diagnose the patient who to have a Crohn's disease, and all these things are non-specific, and these are the chronic diseases. And coming on to the again gross pathology of the Crohn's disease, strictures and fistulas are the classical feature of Crohn's disease. The strictures can vary from 1 to 30 centimeter in length, and there can be large ulcers which can be seen in the intestinal lumen. There can be sinus tracts which can be produced in the intestinal lumen. There can be fistula between the two intestines or between any structures in the Crohn's disease, and the strictures are usually late features of Crohn's disease. And fibrosis occurs because of the chronic inflammation, and the chronic inflammation of the transmural aspect of the Crohn's disease causes fibrosis. The classical feature of a Crohn's disease is again the mesenteric fat wrapping or creeping fat. So this fat wrapping or the creeping fat is said to be because of the serosal involvement of because of the serosal involvement of the disease. The mesenteric fat creeps on the serosa, giving a classical appearance of a fat wrapping or the creeping fat from the mesenteric end to the antimesenteric border. And the mesenteric adipose tissue gets hypertrophied, and there is an increased vasculature of the mesenteric fat. That can be pyloric metaplasia in the terminal ileum. And coming on to the ulcerative colitis and the pathological feature, gross pathological feature of the ulcerative colitis, as I said earlier, there will be increased the involvement of the mucosa is there, and there won't be any involvement of the muscular layer of the colon. And the pathological features are there can be hyperemic edematous granular disease in the mild diseases, and the mucosa becomes hemorrhagic with visible punctate ulcer. Here we can see in the second picture, we can see the punctate ulcers here and there in the colon, and the mucosa becomes featureless. In the severe form of disease, the whole of the mucosa is involved with here and there could be isolated mucosa of the mucosa which are normal. However, the whole length of the intestinal wall will be, or the colonic wall will be involved. And when there is a chronic disease, there's a chance of pseudo polyps which can become low grade dysplasia, high grade dysplasia, which leads on to the chances of malignancy. And the severe diseases causes acute dilatation of the colon, and there can be chances of perforation. And in ulcerative colitis, there can be chances of small fragments of islands of normal mucosa. And the most important thing which I want to stress is the ulcers in the uh, ulcerative colitis has got overhanging edges. That means the edges of that can be undermined edges or the overhanging edges of the mucosa, which is a classical feature of ulcerative colitis. So, as such, in the pathology in the slide, we can see the cryptitis with the abscess with neutrophils within the crypts. And when the patient has got chronic colitis, there can be presence of lymphoplasmacytosis or plasma cells in the muscularis mucosa, and there is a distortion of the crypts in the intestinal wall. I'll show this in the next picture. So this is ulcerative colitis. This is the normal colonic picture with the ulcerative pictures on the side. So the crypts become bifid when there is a chronic inflammation. There is a chance of crypt abscess formation and then in the crypts, and there can be neutrophilic infiltration in the colonic crypts. So these are the classical pathological features of the ulcerative colitis when we see it under the microscope. There can be edema of the lamina propria, which is not classical for which is common for both ulcerative colitis and the Crohn's disease. So what happens during the healing phase of the ulcerative colitis? During the healing phase, as I said, the epithelial cells become cuboidal with eccentric large nuclei and prominent nuclei, and there is a chance of dysplasia which can be present in ulcerative colitis. And there's a chronic in the chronic quiescent phase of ulcerative colitis. There's, as I said, crypt distortion happens. There's a bifid glands of the crypts and wide separation of the mucosal glands in the intestinal wall. The non-specific changes which can happen in ulcerative colitis are neuronal hypertrophy, my fibromuscular hyperplasia of the muscularis mucosa, and there is a shortened gland that do not extend down to the muscularis mucosa. This is a classical feature of perianal disease of Crohn's disease, where you can see plenty of fistulae, and which is otherwise called as water can perianum, and these are the abscesses and fistula are more common with Crohn's disease. As I said, there can be fistula between the two small intestines, which is called as enteroenteric fistula. It can be between coloenteric fistula between colon and the small intestine. There's a chance of fistula in the Crohn's disease from between the ureter and the pelvis of the kidney to the small intestine, and that can be colovaginal fistula or colovesical fistula. In colovesical fistula, we can see patient with nematuria or fecaluria, that means passing gas in the urine and passing feces in the urine. And these enterocutaneous, okay, for example, when a patient undergoes appendicectomy and there is an intracutaneous fistula following an appendicectomy, it has to be assumed that there is a chance of inflammatory bowel diseases which which happened in the appendicitis that can produce intracutaneous fistula after an appendicectomy. So any patient who has got intracutaneous fistula after appendicectomy, we have to think about inflammatory bowel diseases. So how the chronic Crohn's disease and the ulcerative colitis are classified? So the Montreal classification of Crohn's disease includes three criteria: age at onset and age of diagnosis, and the location of the Crohn's disease and the behavior of the Crohn's disease. They have given the numbers for the age of onset: A1, A2, A3, and the A1 is below 16 years of age, A2 is 17 to 40, A3 40, more than 40, and depending upon the location of the Crohn's disease, they have given it as L1, L2, L3, L4, ileal colonic, iliocolonic, isolated upper disease. And as I said, due Crohn's disease can involve any segment of the intestinal wall, and the behavior of the disease like non-structuring and structuring diseases. Depending on that, it's given as B1, B2, and B3, and the P is referred to as perianal disease. Coming on to the again classification, Montreal classification for ulcerative colitis, there's other classification called as Paris classification, which is not usually used. And the ulcerative colitis we can remember these classification in such a way that the ulcerative colitis starts in the rectum, so that the E1 is given for proctitis, E2 when it ascends up to the left side of the colon, and E3 if the whole of the large intestine is involved, extensive or proximal to splenic fracture. Likewise, the severity of the disease, it has been said as S0 for clinical remission when there is no symptom, or when the symptom gets settled down, and S1, S2, and S3 for mild, moderate, and severe ulcerative colitis. So this is a consolidated slide for extra-intestinal manifestation of inflammatory bowel diseases. 6% to 25% of patients with inflammatory bowel disease express any one form of at least any one form of the extra-intestinal manifestation. The most commonest extra-intestinal manifestation is clubbing, and the other group of manifestations are musculoskeletal manifestation, especially ankylosing spondylitis and sacroiliitis bilateral. The sacroiliitis has to be bilateral, both right and left side has to be involved uh, to say that it could be because of IBD. And all these associated extraintestinal manifestations, most of the extraintestinal manifestations have got common gene involvement like HLA-B27 gene involvement, and other musculoskeletal extraintestinal manifestation is arthralgia, and arthralgia because of use of monoclonal antibodies against TNF, and the avascular necrosis because of use of corticosteroids in the treatment of inflammatory bowel diseases. And other the mucocutaneous extraintestinal manifestation most common is the pyoderma gangrenosum and the erythema nodosum. And the mucosa involvement can be represented with aphthous ulcer, aphthous stomatitis, and this aphthous shows that it is a granulomatous non-caseating granulomatous lesion. The rare manifestations are of the mucosa are leukocytoclastic vasculitis, Sweat syndrome. These are the rare manifestations. As I said earlier, in the skin manifestation, pyoderma gangrenosum is more commonly associated with Crohn's disease, erythema nodosum. We'll see this in the next few slides. Other ocular manifestations are anterior uveitis, episcleritis, and scleritis, and the vascular malformations. So there's a chance of venous thromboembolism, and the anemia can be because of malnutrition, and the distal terminal ileal involvement by Crohn's disease or the ulcerative colitis. The hepatobiliary extraintestinal manifestation, it's more commonly associated with it's associated with primary sclerosing cirrhosis, where the chances of ulcerative colitis going for malignancy is high. The other associated extraintestinal manifestation is cholelithiasis, which is more common in Crohn's disease because of the involvement of the terminal ileum and because of the involvement of the um, uh, bilirubin reabsorption, or intrahepatic. There's a disturbance in the intrahepatic circulation of the bile. And the other the next comes with the renal manifestations. External manifestations are interstitial nephritis and nephrolithiasis. In general, as this is a chronic disease, there's a chance of amyloidosis, and other respiratory and cardiac causes are like chronic obstructive pulmonary diseases and cardiomyopathy. So these are the overall picture of extraintestinal manifestations of inflammatory bowel diseases. So as I said, clubbing is the most common, and ENaC was form of extraintestinal manifestation. Pyoderma gangrenosum can happen in any part of the body. It is more common in the leg, and it is more common around a stoma. As I said, erythema nodosum is again much more commonly seen in women, and it has been said that these extraintestinal manifestations flares up when the inflammatory diseases are actively are active. When there is a remission of symptoms of inflammatory disorders, again these extraintestinal manifestations uh, gets resolved by itself with the treatment or with the treatment. So in these pictures, you can see the erythemonodosum on the back and the episcleritis, nodular episcleritis and diffuse episcleritis on the left hand side of the picture. So this is a overall picture so far what we have dealt with, and everything I think almost I dealt with all these things: depth of the invasion in Crohn's disease and ulcerative colitis, distribution, as I said you, it can involve anything, any segment. Fistula more common with Crohn's and less common as absent or less common with ulcerative colitis. Histopathology, as I said, the granulomas, especially non-caseating granulomas, and in ulcerative colitis, the crypt abscess are more common. Crypt abscess and the ulcers are extensive. Ileal involvement is more common in Crohn's disease. Mucosal lesions, perianal lesions are again more common in Crohn's disease compared to ulcerative colitis. Rectum, usually the Crohn's disease has got rectal sparing diseases, but the rectum is invariably involved in ulcerative colitis. Serosal disease, as I said, you serosa is more commonly involved in Crohn's disease, and the serosal involvement is less in ulcerative colitis, except for severe colitis. If there is a severe colitis, a toxic megacolon, serosal involvement may be there. And the serology, deal with the serology in the next few slides. So coming on to the investigations of inflammatory bowel diseases, any patient with any diseases as needs routine blood investigation to check the general condition of the person. C-reactive protein shows an acute inflammation of any chronic disease. The use of fecal calprotectin and protectin and or lactoferrin will be I'll say you about these two things in the next few slides. Stool examination is more important to know the cause of the diarrhea, cause of the abdominal pain. If there is an infective cause of diarrhea, that has to be treated, and there is no cause has been found out, have to think about inflammatory bowel disease. Endoscopy is the confirmatory, or it's the best investigation to say uh, to rule out inflammatory bowel diseases. In endoscopy, we can check the mucosa under direct vision. We can take biopsies under direct vision. You can see the pattern of the ulcers and the luminal pathology. The classical features like cobblestone appearance of the mucosa and luminal narrowing can be assessed easily through an endoscope. And again, coming on to the ulcerative colitis, sometimes the sigmoidoscopy can help you to pick up the diagnosis and confirm the diagnosis. Usually, for an endoscopy, for a colonoscopy or sigmoidoscopy to be done, to diagnose the inflammatory bowel diseases, better to use a tap water enema rather than a full bowel preparation using other chemical forms of bowel preparation, because the tap water enema gives a clear picture rather than the can create erythema, which can mislead the diagnosis of inflammatory bowel diseases. So these are the endoscopic pictures of the ulcerative colitis. These three pictures of the normal colon, and there's a mild inflammation of the mucosa in the fourth picture. So the same thing is these are the mild form of ulcerative colitis. On the other hand side, on the left hand side, these are the severe form of ulcerative colitis, where the mucosa can start bleeding even by small touch in the endoscope. There's a chance of hemorrhagic. Uh, uh, these patients can have hemorrhagic mucosa, and the endoscopy. So these are the radiological features of the inflammatory bowel diseases. In the first picture, we could see the strictures in the this is the barium swallow, which shows the small intestine with a long, lengthy, stricturous small intestine. And these are classical features of Crohn's disease where there is a lengthy stricture. This is the terminal ileum where there is a lengthy stricture of the Crohn's disease. When in this CT picture, we can see there's a thickened intestinal wall, distal ileum, which can be a classical feature of Crohn's disease. Other radiological investigations are MR enterography and uh, enterography. I don't think the ultrasound has got a role. Yeah. So ultrasound have improved distinction between inflammatory and stenotic strictures, but with the use of CT, we can pick it up. We can pick everything. So again, this picture shows the uh, rose thorn appearance of the Crohn's disease, and the string sign of the Crohn's disease, where there's a multiple stricture in the Crohn's disease, and this is a lead pipe stem colon where there is a loss of ostration in the colon, can which can be either Crohn's disease or the ulcerative colitis. Here we can see the host pipe or lead pipe colon in the ulcerative colitis, and there is a gross dilatation of the colon, which is seen in toxic megacolon with loss of obstructions in this picture. So barium studies were historically used, and even nowadays we do still use barium studies. And standard CT cannot demonstrate mucosal details. However, CT can pick up the strictures easily. MR enterography has got advantage in high soft tissue contrast, especially to obtain static and dynamic images. The role of capsule endoscopy is a controversial thing. When there is a patient who has Crohn's stricture, the capsule endoscopy cannot be used because there is a 2.6% chances of capsule retention, and it has to be used in a sensible manner. And the sensitivity, its capsule endoscopy is more sensitive than specific. And how to measure the disease activity, especially in Crohn's disease? There's something called as Crohn's disease activity index, CDAI. So we can have this chart in the clinic so that we can assess the disease severity, disease activity index, which includes the criteria, which includes the number of stools, abdominal pain, and general well-being, extra-intestinal manifestation, use of opiates for diarrhea, abdominal mass and hematocrit value, and body weight. Each and every criteria, every disease, every symptoms, and the features are given some weightage, and these weightages are calculated, summed up to show how the patient responds. When this CDAI is the if the CDAI scores is less than 150, if it is less than 150, the remission is widely accepted. That means the patient's symptoms are settling down when the CDAI score is less than 150. But and also the drug response is monitored with the CDAI score, and if the response is not, if the points are not less than 100, so the drug has not is not effective. So likewise, the use of biomarkers like CRP and fecal calprotectin, the sensitivity of the fecal calprotectin protectin is 88%, and the specificity is 73%. This is for uh, Crohn's disease. However, for ulcerative colitis, the fecal calprotectin sensitivity is 79% when compared to the Crohn's disease, it is 67%. In general, fecal calprotectin can be used to screen the patient for inflammatory bowel diseases. However, this is not a standard investigation to confirm the diagnosis, and the most best investigation to confirm the diagnosis will be an endoscopy or the colonoscopy or the sigmoidoscopy. So how the disease activity of the ulcerative colitis is monitored or uh, assessed. So there is no standard index exists for evaluating the severity ulcerative colitis like CDAI. The CDAI is universally used and it has got good implication. However, for ulcerative colitis, there are plenty of disease activity indexes. The most commonly used is Truelove-Witts classification, and there are also Mayo score for severity index, and different criteria has been used in different different indices. We can use any one. And the next thing is management of inflammatory bowel diseases. The most important principles of management of inflammatory bowel diseases is achievement of symptomatic remission. That means the symptoms has to be decreased as much as possible, and try to keep the symptoms under control. So first the symptom has to be relieved, and that gains the remission, and the maintenance again should be done. In Crohn's disease, the best investigation, as I said, your endoscopic healing is more important than the symptom remission, because even though the symptoms are the patient, even though the endoscopy shows a normal, even the symptoms are that the endoscopy can be normal. So again, there is another thing called as Crohn's disease endoscopic index of severity, CDEIS, and this is also helpful in assessing the patient in the management of inflammatory bowel diseases. Again, in the same way, ulcerative colitis has got Mayo endoscopic score of 0 or 1. Again, Mayo endoscopic score. So in general, endoscopy helps in disease management and assessing the disease progress, and the criterias and scores are given as per the endoscopy, and the disease pattern or the disease remission is assessed. Coming on to the medical therapy, I'll be dealing with medical therapy in short, as we are going to deal with the surgical aspect much more than the medical therapy. There are plenty of drugs which are used, especially the steroids, sulfosalazines, and immunomodulators. Sulfosalazine is the most commonly used drug, and the sulfapyridine moiety is the uh, drug which is more prone, which is the part of the drug which causes the plenty of complications, and it prevents the absorption of 5-ASA in the intestine and keeps the 5-ASA in the intestinal lumen and causes action on the intestinal lumen. The most common complications of sulfasalazine is nausea, vomiting, heartburns, headache, and oligospermia, and lower level of hemolysis. And the sulfasalazine has got very good role in ulcerative colitis, and has got less role in Crohn's disease. And these are the other preparations. Either it can be prepared in the topical form, in the form of enema, or in the form of or in a oral form. There are plenty of formulations which has been there, and the mesalamine preparation is another form of 5 5-ASA or amino salicylic acid. So how this works out? Okay, this is the treatment flow chart for ulcerative colitis, when the patient can be managed with medicine or medical management of ulcerative colitis. The mesalazine suppositories are more effective than the oral 5-ASA compounds. This is in general. And okay, let's go on to the flow chart. So the patient who has been diagnosed with ulcerative colitis are start with topical or oral 5-ACA, and there's a good response, just go for a maintenance therapy with sulfasalazine. When there is a poor response, add some dose of glucocorticoids or oral steroids. And there's a good response, taper the steroids, keep the patient on maintenance therapy with 5 aminosalicylic acid of sulfasalazine. And if the patient are unsuccessful after trapping when the symptoms comes back, when the treatment is unsuccessful with the steroids and the 5-ASA, go for purine analogs like 5-mercaptopurine or azothioprine, and then maintain the patient with 5-mercaptopurine or azothiosin. Okay, when there's a poor response for any glucocorticoids at the first instance, before tampering the glucocorticoids, and if there is a poor response, start the patient on 5 mercaptopurine or azothioprine. If the patient is not responding to 6 mercaptopurine or azothioprine, consider IV cyclosporine or infliximab or targeted therapy. Even if the patient is not responding to targeted therapy targeted therapy or immunomodulators, if there is a poor response, go for surgery. If there is a good response, continue with the uh, steroids or infliximab, and go for glucocorticoids, slowly decrease the doses and try to continue the maintain the dosage with 6 mercaptopurine or azothioprine. Better to avoid long-term glucocorticoids, that's the dictum, and try to use immunomodulators or sulfasalazine. Glucocorticoids are used especially for acute phases. And if the patient has got good response to purine analogs, try to maintain the patient on either sulfasalazine or purine analogs. In general, three drugs are involved. One is sulfasalazine, glucocorticoids, and purine analogs, and then comes the targeted therapy like infliximab. Start the patient on sulfasalazine. If the patient is not responding, start on glucocorticoids. Taper the glucocorticoids. If the patient has good response with glucocorticoids, taper the glucocorticoids. Maintain with sulfasalazine. The patient has got poor response with glucocorticoids, start the patient on purine analogs. The patient has got good response with purine analogs, go to the just maintain the patient with purine analogs or the 5-ASA. The patient has poor response with uh, purine analogs, go for targeted therapy. The good response, if the patient has got poor response with targeted therapy, go for surgery. If it has got good response, go for purine analogs maintenance. So, in general, as I said, the maximum dose of glucocorticoids which is going to help is 60 milligram of prednisolone. The patient is not responding to 60 milligram of prednisolone for first few weeks, maximum of 12 weeks. Wait for 12 weeks to get the response. If there is no response, the patient is not going to respond for prednisolone. And uh, very low dose of glucocorticoids, again, it's not going to be helpful. And if the doses are going to be more than 60 milligram, again, it's not going to be helpful. And do not treat for long term period. The maximum period we can try with glucocorticoids or steroids for maximum of 6 weeks. Sorry, it's maximum of 6 weeks, and it can be helped up to 2 years for remission to just to treat the symptoms. So as I said you already, immunomodulators, the most two important immunomodulators are azothioprine and 6-mercaptopurine. Azothioprine is the pro form of the 6-mercaptopurine, and the therapeutic effect starts from third to 6 months. It does not show its effect immediately after the intake of these immunomodulators. And the adverse effects of bone marrow suppression and hepatotoxicity And for Crohn's disease, one of the patients may respond to therapy once in remission. About half of two-thirds of the patient will maintain that response. So, in other words, immunomodulators are good for Crohn's disease. Initially, they do not respond, but later on, they can respond. The, the, the mechanism of action of mode of action of methotrexate is it inhibits DNA and RNA synthesis by inhibition of DHFR, dihydrofolate reductase inhibitor. So the methotrexate is always given with folate supplements. And the other side effect of methotrexate is there are 3 to 15% of the patient can develop pancreatitis. So this is the medical therapy for medical management of Crohn's disease. Any patient who has got moderate to severe active Crohn's disease, start the patient on oral steroids as 5 alpha 5 ASA may not be that much helpful. And if the patient has got remission of symptoms, try to use methotrexate, thiopurine for maintenance of remission. And other drugs, if you start the patient on other drugs like immunomodulators or targeted therapy, try to maintain the patient on the same targeted therapy. And aminosalicylates, steroids, and azathioprines are relatively safe in pregnancy, and doesn't mean that it doesn't cause any uh, uh, congenital malformations. There are chances of congenital malformations, and compared to the disease severity, these are relatively safe. There are few studies which compares the medical management of the inflammatory bowel diseases. Accent 1 study compares the placebo with infliximab, and they have proved that Crohn's disease is helpful with infliximab. In Accent 2 study, they have studied infliximab with placebo for Crohn's disease fistula, and they have proved infliximab in perianal fistula or Crohn's disease fistula has got good good efficiency on the Crohn's disease fistula. Classic 1 and 2 and the charm study compared the infliximab with adalimumab. So these are the two drugs which are used as a last entity. If the infliximab therapy is not helpful in Crohn's disease, we can use adalimumab for infliximab. And in this study, it shows that either one can be used as a maintenance therapy for the treatment of Crohn's disease. If one is not effective, the other can be used. The other can be used. So everyone knows that ulcerative colitis or inflammatory bowel diseases with ulcerative colitis, there is a chance of colorectal cancer. How much is the chances of the colorectal cancer in ulcerative colitis? When a patient has got chronic ulcerative colitis, there is a 2% chance of colorectal cancer in 10 years, 8% chance of colorectal cancer in 20 years, and 18% chance of colorectal cancer in 30 years. So the relative risk of ulcerative proctitis is estimated to be 1.7 for rectum, and if the patient has got ulcerative colitis in left side of the colon, it is 2.8, and pancolitis, there's an increased risk of colorectal malignancy in ulcerative colitis when the patient has got pancolitis. So that's why the reason for surveillance colonoscopy is more when there's a chances of pancolitis. So there are two criteria which has been included here. One is flat low grade dysplasia and flat high grade dysplasia. So the flat low grade dysplasia has got 14% chances of malignancy and 53% of chances of malignancy after 5 years. When there is a high grade dysplasia, there is a 42 to 45% chance of colorectal malignancy. And the surveillance endoscopy is needed every 1 to 2 years after the diagnosis of pancolitis with ulcerative colitis, and this decreases the in this helps us to pick up the uh, colorectal malignancy in ulcerative colitis. When the patient goes for colonoscopy, how many biopsies has to be taken if the patient has got inflammatory bowel disease, and at least 20 to 40 biopsies per colonoscopy is indicated to diagnose a patient with inflammatory bowel disease, and also to no, and also to rule out malignancy and dysplasia. These 20 to 40 biopsies are needed either from the representative site or from the non-representative site. And in an average, it has been found that 33 non-targeted biopsy are required to detect dysplasia with 90% confidence interval. So coming on to the surgical management of ulcerative colitis. So what is the indication of surgical management? As I said you already, when the patient is not responding to the medical management like duct intolerability or unresponsiveness, intractability, life threatening complications like perforation, bleeding, and toxic megacolon, when there is a chance of dysplasia, when there is a high grade dysplasia or malignancy, and the growth impediment in children, if it is in the children and uh, it interferes with the child growth, we have to think about surgical management. And for sometimes to improve the extra-intestinal manifestations, especially pyoderma gangrenosum, erythema nodosum, the surgical management can be helpful. So what are the surgical options? So I'm not going to deal about the procedure here. I'll say the surgical options and what are the indications for that surgical options. Most common surgical option for ulcerative colitis is total abdominal colectomy with Brooks ileostomy. And here in total abdominal colectomy, we don't remove the rectum, and the rectum has to be the patient has to comply with the option of regular rectal surveillance, and Brooks ileostomy is a permanent ileostomy. Proctocolectomy is the best thing because we remove both rectum and the colon, and if the use of removing both rectum and the colon is there is a decreased incidence of disease in the rectum removal of after the removal of the rectum. And the next option is proctocolectomy with continent ileostomy. I'll be saying about this continent ileostomy in the next few slides. And total abdominal colectomy with ileorectal anastomosis. In this, again, the patient has to comply with continuous surveillance of the rectum because there is a chance of ulcerative colitis which can be flaring up in the rectum because the rectum is not removed, and the rectum is kept for the purpose of anastomosis and the purpose of avoiding stoma. And proctocolectomy with ileoanal reservoir or ileal pouch anal anastomosis. I'll say about this procedure in next few slides. And coming on to the emergency urgent management of surgical options for ulcerative colitis, all this, as I said you, the urgent emergency management for emergency surgical management for ulcerative colitis because of perforation, toxic megacolon, and when there is a patient presenting with emergency. And sometimes to preserve the bowel, the Turnbull procedure is helpful. The Turnbull procedure is nothing but two ileostomies, especially one is transverse ileostomy, one is transverse colostomy, transverse loop colostomy, and next one is transverse loop ileostomy, sometimes cecostomy. So these all the openings uh, comes to the skin and diverts the inciting agents like bowel content on the intestinal mucosa, decreases the severity of the disease in the intestinal mucosa, and tries to preserve the intestinal mucosa. However, this procedure is not used usually practiced because not that much helpful. So coming on to the Brooks ileostomy, it's an end ileostomy wherein the mucosa of the ileostomy is averted to the maximum at least 4 centimeter to avoid the spillage of the content on the skin to cause complications of the ileostomy. And there are types of ileal pouches, as I said earlier, ileal pouches used in the surgical options of inflammatory, especially the ulcerative colitis. So different types of ileal pouches are J, S, H, and W. All these names are given depending on the shape of the pouches. So this ileum is given the shape of the J, so it is called as J pouch, and this is given with the S, H, and W depending on the shape of the ileal pouches which is created. Advantage of J pouch is easy to construct and less of complication, and the disadvantage is the less amount of fluid which can be, the capacity of the J pouch is less when compared to the all rest of the three. And one loop of intestine is added to the J to create AS pouch. Again, the advantage is it gives support to the J pouch, and also the content, the luminal content, the capacity is more compared to J, and there's a chances of uh, pouchitis or inflammation of the pouches in H variety, H type of ileal pouch. And when we do a W type of ileal pouch, it's time consuming. The advantages, the increased luminal content has got the retention capacity, more retention capacity compared to all the three types, but it's time consuming, and there is the complications rates are high when we do a plenty of ileal pouches. So coming on to the technique, what is the technique of the ileal pouch anal anastomosis? It's IPAA. So I'm going to deal about this IPAA, which is the indication of this is ulcerative colitis and toxic colon. Patient can be chosen as an elective patient, can't be done in an emergency where there is a spillage of toxic fluids in the intraperitoneum. So the best thing, the procedure involves transect the ileal at the level of the ileocecal junction, or 10 centimeter proximal to ileal junction, and try to reflect the mesentery up to the duodenum, and transect the ileocecal artery at the level of the origin from the superior mesenteric artery, so that the length of the mesentery can be obtained. This length of the mesentery helps the ileum, which forms the which is going to be forming the pouch, uh, to reach the perineum. The most important thing is try to transect this, as I said, you transect the ileocecal artery, and there's a mesenteric incision which lengthens the mesentery. The ideal thing how to clinically assess or on table assessment of ileal mesentery or ileum is try to bring the ileum to the pubis or root of the penis or root of the suprapubic region. If the intestine reaches the suprapubic region, so that means the intestine can reach the perianal region for pelvic floor for anastomosis. So after we do this, transect the rectum, complete the colectomy, and try to create a pouch like this. This is a J pouch where the stay stitches are applied on the ileum, and use a stapler TLC 55 or 75 depending on the need of the patient, need of the depending on the need. Stapler it on the antimesenteric border so that the pouch is created, and on the other end, the end where the stapler is inserted, use a circular stapler to bring the pouch into the perianum and complete the anastomosis in the perianal region, with the pouch being anastomosed to the uh, part of the rectum or the left out part of the rectum. The most important complication of this procedure is strep proctitis or cophitis. That means the left out part of the rectum. There is a chance of ulcerative colitis in the left out part of the rectum, which causes the pouch to be which causes the failure of this surgery. And other complications are small bowel obstruction, anastomotic stricture, pouch vaginal fistula, and the pelvic abscess. So all these things are other complications, but the most common complication is the strep proctitis or cophitis. So the functional outcome. So after any pouch surgery, IPA surgery, the functional outcome will be 6 stools in 24 hours. That's a normal thing for any pouch surgery, ileal IPA surgery. Functional outcome. That's actually good outcome if the patient has got 6 stools per day, and the incontinence is more common during less common during the daytime, like 11% during the day and 21% at night time. There can be the patient has got 90% of the patient has got overall satisfaction, and the long-term functional and the clinical outcomes are very good. And 5 to 10%, 7 to 10% chances of pouch failure at 10 years is normal. And the success rate for salvage surgery, the salvage surgery is nothing but if there is a patient has got pouch failure, the the salvage surgery includes complete removal of pouch and bringing back the intestines to the um, with ileostomy. So the success rate for salvage surgery is 75 to 94%. The advantage of this IPAA is the patient is avoiding stoma, and the patient is more comfortable with IPAA. And the principle of this surgery is we are not operating on any patient with malignancy. It's a purely non-malignant condition. So there is a chance of good response for these patients. So coming on to the continent ileostomy, as I said you, continent ileostomy. There are two types of continent ileostomy. Nils Koch, Koch's ileostomy. Continent ileostomy is more commonly used. And the other one is Barnett, and minimum of 30 centimeter of small intestine is needed to create a pouch reservoir for continent ileostomy. It has been we can do a hand sewn or stapler anastomosis of two intestinal on the corresponding intestinal wall to create a pouch like this. And the valve is created by intersuscepting. So that means the distal bowel is invaginated into the proximal bowel here to produce a valve. This is called as continent ileostomy. So this intersusception helps in creating a valve mechanism for this reservoir, and this helps this reservoir keeps the fluid keep the intestinal content for a while. And at a particular time the patient can insert a large wide bore catheter into the stoma site. Usually the stoma are flushed in the continent ileostomy, not like Brooks ileostomy where there is a protrusion of the stoma. In the continent ileostomy, the stoma is flushed with the skin, and the catheter is inserted into the uh, reservoir. Thereby, it drains the content. Usually, 6 to 8 times the reservoir is emptied. There is a chance of wall slippage. That's the common complication, and there's a chance of 10% fistula in these patients. So coming on to Barnett continent ileal reservoir. So what is the modification of Koch's reservoir continent ileostomy with the Barnett is there's a loop of intestine around the stoma which has been created to give a bowel wall or to give a sphincteric mechanism on the ileostomy site. No, I don't have much experience on this. So coming on to the next thing is the surgical management of Crohn's disease. The main principle of surgery for Crohn's disease is it's a microscopic disease, and we are not dealing with any malignant disorder. So it's a microscopic disease. There's no need for very there's no need for resection margin or anything for these diseases. And so try to resect as close to the pathology as possible. And the other thing, most important principle is fistula. Any fistula which has not been treated for 12 weeks, it's not going to heal. So the patient needs surgical treatments or surgical management. And as for other surgeries, the perioperative considerations are same, like preparing the patient, electrolyte correction of electrolyte, correction of the malnutrition, and all the rest of the things are very important, especially for Crohn's disease, because these patients go for malnutrition very easily. And the techniques, again, make sure that uh, uh, we don't go for a obvious uh, uh, disease, obvious complicated procedures. Most important thing is the surgeries is required in the Crohn's disease for stenosing obstructive diseases, and when the patient has got intracutaneous fistula or intra-abdominal fistula with other organs, and when there is a abscess, and to control the acute or chronic bleeding, when there is a free perforation, is these are the indications for surgery in patients with Crohn's disease. As I said earlier, Crohn's disease can happen in any part of the intestinal segment from mouth to anus. So we are going to think about different aspects of Crohn's disease in different segments of the intestine. If it happens in the gastroduodenal diseases, usually it is just 5% of the Crohn's disease. Upper GI Crohn's is just 5%, and that commonly occurs. Mostly the Crohn's disease in upper GI occurs in first and second part of the duodenum. So in that scenario, if the patient has got first the patient has got stricture or the fibrosis of the first part of the duodenum or second part of the duodenum, gastrojejunostomy is the standard procedure which is helpful. And no, the dilatation usually doesn't help, because in Crohn's disease, any patient who has got uh, Crohn's disease can go for with stricture can go for fistulation. So dilatation is not going to be helpful. The patient will be helpful with gastrojejunostomy. Either it can be anterior or posterior, as it is a benign. Posterior gastrojejunostomy is better. So coming on to the ileocolic disease, usually the ileocolic disease needs resection, and the dilatation can be helpful if the ileal segment, if the terminal ileum stricture is less than 4 centimeter. However, the reoperation for any balloon dilatation in 5 years is 20 to 25%, and 10 years, and in under 10 years it is 35 to 40%. So much more easy way is ileocecal resection is easiest way to avoid um, resurgery after 5 years or 10 years. So the most another important technique which is used for strictures of Crohn's disease is stricturoplasty. So there are two types of stricturoplasty. One is Heneke-Mikulicz technique, which is used for any strictures which is less than 10 centimeter. So usually it is used priorly, like this is not the picture which I can say for small bowel strictures. What this is actually in the upper GI, where there is a pyloric stricture for DU obstruction or duodenal ulcer, chronic duodenal ulcer. We use this Heneke-Mikulicz technique, where we make a longitudinal incision on the intestinal wall and suture um, longitudinal incision transversely, so that the stricturoplasty is completed and the lumen gets widened. So this is Heneke's Mikulicz technique, where it is applicable if the stricture is less than 10 centimeter, and the Finis or Gervais stricturoplasty is applicable if the stricture is more than 10 centimeter up to 25 centimeter. What happens in this procedure is we make a loop with the stricturous end on the distal, and the proximal end is on this aspect. So the stricture is continuously, the stricture is made as a loop, and the antimesenteric borders are opened and made as a lumen, continuous lumen like this. So this is called as Jaboli stricturoplasty or finis disc stricturoplasty, which is applicable for long strictures. So how are you going to treat the spontaneous enterocutaneous fistula due to Crohn's? Always, when there is a Crohn's, try to treat the patient conservatively, and medical management will help if there is a fistula. And these spontaneous fistulas, uh, usually, when the uh, disease has got its remission, it gets settled. However, when there is if the fistulas are not getting treated after 12 weeks, usually they need a surgical correction. So intra-abdominal fistulas usually is an incidental finding, and try to resect in block when there is an intra-abdominal fistula, if it is enteroenteric fistula or intracolic fistula. And if there is a spontaneous free perforation of small intestine or large bowel, complete resection of the particular involved segment is done. And these are the surgery for colonic Crohn's disease. As in ulcerative colitis, here in Crohn's disease, if the patient has got Crohn's disease, if there is an involvement of colon with Crohn's disease, ileal pouch or ileal pouch IPA is not usually advised, because the ileal segment is more prone for Crohn's disease. So the patient may be, in patients those who have colonic Crohn's, may end up with ileostomy. And most of the time, the surgery is indicated if there is a toxic dilatation of the colon, hemorrhage, perforation, severe colitis. And total colectomy with ileorectal anastomosis is usually done, because rectum is usually spared in Crohn's disease. And the as I said, you 25% have rectal sparing. And pan-proctocolectomy, even if the rectum is involved, and try to don't try to do a pouch, ileal pouch anal anastomosis, as it is a Crohn's colitis. And as I said, you been regarded as a contraindication for ileal pouch. So again, perianal lesions of the Crohn's has got a classification called as Hughes Cardiff classification, and there are different types of Hughes Cardiff classification. If anyone needs to see this, they can go into Google and they can search the broad way of classifying the perianal diseases: primary lesions, secondary lesions, and incidental lesions. The primary lesions of the Crohn's disease is anal fissure. Usually, anal fissures are posterior, and the awkward anal fissures, like lateral fissures, are more common with Crohn's disease. And ulcerated edematous piles, cavitating ulcer, and aggressive ulcers are the primary lesions of the perianal disease, of perianal Crohn's disease. The secondary lesions are skin tag, rectal stricture, anal stricture, perineal abscess and fistulas, anovaginal fistula, rectovaginal fistula, and carcinomas. And the incidental lesions are piles, skin tags, cryptitis, and adenitis suppurativa. So these are the two other classifications which I found it from the huge Cardiff classification. They have included plenty of uh, uh, plenty of criteria to classify the perianal disease of the Crohn's disease. And the treatment of anal fissure, as usual, usually conservative. The patient is not treated by medical management or conservative management, go for a lateral anal sphincterotomy. And the lateral anal sphincterotomy is contraindicated if the patient has got active Crohn's proctitis or any active proctitis, which can trigger more, which can cause more harm than the surgery. The patient has got abscess, try to do an MRI and try to find out whether the abscess cavity is supraelevator or transsphincteric, where try to locate the abscess exactly, and try to drain completely. Antibiotics are used in any abscesses and in Crohn's diseases, especially ciprofloxacin and metronidazole are helpful in Crohn's disease management, when the patient has got abscess. And large cavities, we can try to insert a mushroom catheter, which can be, this is a mushroom catheter, where the mushroom catheter helps in complete drainage of the abscess cavity. And when the patient has got anal fistulas, that is otherwise called as watering can or water can perineum, where there's a multiple fistula. Try to do an MRI, try to find out the extensive involvement of the perianum with the fistula. If there is a superficial fistula, if it is intersphincteric, if it is a superficial fistula, try to do an open fistulotomy. And if the main aim of fistula surgery is sphincter preserving, if it is an high anal fistula and if it is intersphincteric, try to ligate the intersphincteric tract. That is called as lift procedure. That is nothing but ligation of intersphincteric tract. So nothing does nothing but the fistulous tract is delineated, and the site of incision will be intersphincteric region. Try to enter the intersphincteric region and divide the fistula, and the fistula tract is disconnected, so that there's an increased chance of healing. And other surgical management is rectal advancement flap, um, wherein the rectal mucosa is advanced. We remove whole of the tract, and rectal mucosa is advanced to cover the area. So most devastating are difficult to treat pathologies in the Crohn's disease are rectovaginal fistulas, and in rectovaginal fistula, involvement of the other departments are more important. There are two things which are involved in the treatment of rectovaginal fistula. There's something called as MRCS flap, where the pedicle fat is brought between the fistula, between the two luminal surfaces, vagina and the rectum, and the vagina is closed, and the rectum is closed with a pedicled vascular pedicle flap between the two lumens, which helps in the management of rectovaginal fistula. Likewise, the gracilis interposition flap is used. Gracilis is used to cover the perianal region when the patient has got rectovaginal fistula. And sometimes these fistula can be treated with a temporary ileostomy, whereby the inciting agents are taken off and the fistulas heal. Then we revert back the ileostomy. So, what is the prognosis of Crohn's disease after surgery? The mortality rates are higher for Crohn's disease when compared to the ulcerative colitis, and the ratio is 1.4. And the most common complications of the Crohn's disease of sepsis, perioperative complications, electrolyte disturbances, and gastrointestinal tract cancers, like in especially in the colon. Surgery for small bowel disease is usually necessary because of complications of diseases such as strictures and fistulas, and surgery for large bowel disease is usually necessary because of inability of medical treatment to control symptoms. So these are the indications for surgery in these are the causes of the disease. The first sentence is for the Crohn's disease, and the rest of the things are for in rest of the things are in general. Thank you all for listening to me. And there are three participants in this section, and I think there'll be plenty of people from the should be uh, in the online in YouTube. Thanks for listening to me. And if there is anyone who needs for discussion, can unmute themselves. They can unmute and they can go for any question and answer session if they are interested. Happy to listen to any questions. Sorry, just a minute. Sorry, can you please come again? Sorry, I don't hear. Sorry. Can you please be audible? I could hear something, but I'm not able to hear properly.
I am, please, doctor. Dr. Farah?
I'm extremely sorry. I'm not audible. I don't know what.
Dr. Farah? Dr. Farah? Dr. Farah? I am ask.
Some technical issues, if I'm not wrong. I don't know.
Doctor?
Yes, if anyone wants anything, please type on the chat box so that I can reply.
I am ask. Doctor. Dr. Farah?
Hello.
Hello?
Yes, please.
I am ask. What is the surveillance of the colonoscopy after
What
total
is the?
collect? You hear?
Really not audible. Something is wrong with my. I don't know whether it is my connection or with something else. Some problem.
You hear?
Just a minute. I think. Do you hear me?
I am ask. What is the role of the colonoscopy surveillance after colectomy in patient of the inflammatory bowel disease?
Oh my god. Just a minute. I think I have to stop sharing my.
Dr. Farhan?
Hello.
Hello. Welcome, doctor.
Yes, please.
I am ask. You hear?
Yes, please.
I am ask. What is the role of the colonoscopy surveillance after patient undergo colectomy in patient of inflammatory bowel disease?
Okay. If the patient has got rectum after colectomy, the patient needs surveillance proctoscopy. When the patient has got removed whole of the colon, there is no need for any colonoscopy. Just rectum can be continuously monitored. To in case of ulcerative colitis, the rectum has to be monitored as a surveillance. And if the patient has got proctocolectomy, there is no reason for the patient to have um, any surveillance. Am I to the point what you are asking? I think your question is to what's the role of colonoscopy after colectomy?
Yeah.
So when the patient has got colon out, when the whole of the colon is taken off, leaving the rectum has to be monitored in ulcerative colitis, and that's the role of surveillance, and there's a need for surveillance of the rectum in case of ulcerative colitis. If it is a Crohn's disease, better is to do a proctocolectomy rather than colectomy, and there's no need for any surveillance of anything. The patient has got Crohn's disease. colitis. Got
Okay,
it?
doctor. Yeah, I am understand.
Okay, thank you guys. Thanks for participating and thanks for joining here. The next
Thank you.
session will be the anatomy for MRCS, and that will be done in the next few weeks. Thank you. Thanks all for
Thank you, doctor.
joining. Any other questions or anything to be? Thank you. Thanks for joining.
Thank you, doctor.